So as you mentioned, I do mostly transplant ID, but I've always been interested in C. diff, so I thought this would be a useful thing to review. And I know that you all already have a lot of experience with managing C. diff and knowledge, so I'm just going to try to focus on things that I think are new or interesting in the C. diff world, and broadly in these four general categories, with more of a focus on the treatment and prevention aspects, because those are sort of rapidly changing. There's some interesting stuff coming out. C. diff itself is relatively new topic of medicine. Sort of interesting to consider that it was just recognized as the principal cause of antibiotic-associated diarrhea in the late 1970s. So relatively recent discovery. This person at Hopkins, John Bartlett, sort of gets credit for discovering C. diff, although there's some folks in the UK that were sort of concurrently working on it. And initially, the incidence and severity were relatively stable early 2000s, when they both sort of rapidly sort of took off. So this chart is a number of hospital discharges with C. diff as either the primary or any listed diagnosis, and this is the deaths per million population. And you can see that in the early 2000s, that both of those charts really just sort of take off. And more recently, just a couple years ago, there was a review in the New England Journal that estimated that there were about 500,000 cases and about 30,000 deaths annually in the U.S. So pretty striking numbers. And like I said, things have changed in the last 15 years or so. And so the rising incidence and worsening severity of C. diff have been attributed to multiple factors. One is just the overuse of broad-spectrum antibiotics in the healthcare system, but also the aging of the U.S. population, the widespread availability of PCR testing, which is highly sensitive and able to detect more C. diff, and then the emergence of the hypervirulent NAP1 strain, which you may have heard of and was first identified in Quebec, but has since spread here to the U.S. So risk factors, you all know, for C. diff: antibiotic exposure, hospital admission, advanced age, gastric acid suppression like PPI use. Enteral tube feeding is one that isn't always mentioned, but sort of interesting. So people with NG tubes are at high risk for developing C. diff. And then one that I'll mention, it's just sort of recently been described, and I think is also sort of interesting, is immunosuppression. And so there have been several studies in the past few years that have described increased rates of C. diff in immunocompromised patients. So in stem cell transplant and oncology patients, in kidney transplant recipients, and we recently published the experience at Mount Sinai in the liver transplant population. And essentially, in any group of immunocompromised patients that you look at, it seems like, aside from the fact that they have other risk factors for C. diff, like they're sick patients, they've been in the hospital, they're getting antibiotics for other reasons, it seems like being immunocompromised itself is an independent risk factor for developing C. diff. And the thought process is that humoral immunity is required for both treating and preventing C. diff to some degree. And so when you introduce immunosuppression, perhaps these patients are already colonized and C. diff sort of flares up. The other thing to keep in mind is that these patients don't present like your typical patients with C. diff, and that they may not be able to mount the same sort of inflammatory response. So they may not have a fever, they may not have a high white blood cell count, but they actually are at higher risk than your average folks in the hospital. So I have a couple questions in this talk. I wasn't quite sure how this would go over in this group, but I guess we'll see if people are interested in responding to these questions. They're pretty straightforward. So this one is a 75-year-old man with lung cancer, heart failure, CKD, transferred from an outside hospital with pneumonia and C. diff. Per the handwritten outside hospital thing that he comes with, the C. diff PCR was positive. He was started on oral vancomycin 3 days ago, but he's still having water diarrhea, and the nurse says it smells like C. diff. So you send our C. diff test, which is not PCR, but is the current toxin antigen test, and it's negative. So any brave people in the room want to venture a guess as to how you could explain the discrepancy between the PCR test at the outside hospital and the positive test here? There's more than one potential explanation for this. Any thoughts? Okay, so that's one thing.
Colonized but not infected?
Yes, so PCR might pick up colonization and not true infection. Anything else? Other thoughts? Okay, good. So we'll get to that. And then, does anyone know if there's any evidence to support the smells like C. diff claim? People say this all the time in the hospital.
I think there is.
Smells like C. diff.
There's that dog. It's the dog one.
Right. Okay, good. So to review briefly the different diagnostic tests that we have. So back in the old days at Mount Sinai, when I was an intern here in 2009, we had this ELISA test for C. diff, which is highly specific. It detects the presence of toxin, but it's not sensitive. So we used to send it every day in people that we thought had C. diff. You just, oh, he's having diarrhea, send another one. And like I said, if it were positive, then it's highly specific, but not ideal. So more recently, we've adopted this two-step algorithm, which incorporates the C. diff antigen test, which is also called glutamate dehydrogenase enzyme. It's an enzyme that's produced by all strains of C. diff, not only the toxigenic ones. So a positive test indicates that C. diff is present, but not necessarily infection. So it's highly sensitive, but not specific. And so that's the reason why we combine both of them for sensitive and specific testing. We just recently switched to this algorithm, right? So a few years ago, everyone was very excited when we got PCR testing for C. diff, which is very sensitive. But as you mentioned, it detects the presence of the gene regulating toxin production. So it can detect the presence of toxigenic C. diff, but it doesn't tell you if that C. diff is actually causing infection. So slightly different than the C. diff antigen test in what it finds. But the experience here is that we were finding a lot of false positives. There are a few other tests out there, but the first three are the major ones that we use. So some diagnostic pitfalls. So as you mentioned, false positives can occur with PCR testing representing colonization and not active infection. So there are several things that can cause false negatives. One is just the way that the specimen was collected and shipped to the lab. So if the nurse collects it and it sits around for a while, then the toxin can degrade with time, and that reduces the positive predictive value of the test. So relevant to the case that I presented to you, one thing that we often don't consider is that starting treatment before the test is sent can actually cause a false negative. That wasn't something that I was ever taught in med school. I was taught that the C. diff test stays positive for months, forever, but there actually is evidence to support, especially when you're treating with oral vancomycin, that if the patient's been on treatment for a couple of days, then it might cause a false negative test. So that's something to consider. And then in patients who are dehydrated or have severe ileus, just collecting an adequate sample may be difficult, and those cases are sometimes missed. And so, like I said, we switched to this two-step algorithm a couple of years ago, and a lot of other hospitals in the country did the same thing. And a lot of this was largely based on this one study that came out in JAMA Internal Medicine in November of 2015. And basically what they did was they looked at a hospital in San Diego that was ELISA test, which is what we used to use. And then for the study, they also did PCR on all these specimens, but they didn't report it to the doctors taking care of the patients. So what they found was that of the ones that were positive by PCR, less than half were actually positive by the toxin test. And then they looked at the outcomes of the different groups of patients. So did they have toxin positive, PCR positive, or toxin negative, PCR positive? Basically what they found was that the outcomes of the patients who were PCR positive but toxin negative were comparable to patients that didn't have C. diff. In other words, they were just picking up asymptomatic patients with the PCR, and the toxin was really what predicted if the patient was going to develop any sort of complication or had severe infection. And so we and like I said, a lot of other places around the country adopted this two-step algorithm. We still use PCR, but only when there's a discrepancy between the two tests. So if they're both positive, it's positive. If they're both negative, it's negative. And if one's positive and one's negative, then they run the PCR and sort of take the best 2 out of 3 to decide if the patient's positive. Technically, you could still pick up colonization with this way if the antigen test is negative, but I think if you have 2 positive tests, it's considered to be convincing enough to treat the patient, call it positive. Right, so this question of smells like C. diff, I think it's interesting. There are actually a couple of studies that looked at this. This one was published in 2002 in the UK. So they did this prospective study where after a C. diff test was sent, they went back to the floor and they interviewed the nurse, and they asked the nurse a bunch of questions about the patient, what their opinion was, and they looked at some of the predictors of who actually was positive and who wasn't. And so they found was that characteristic odor, per the nurse's opinion, had a statistically significant odds ratio for C. diff. And then the opinion of the nurse was actually the most predictive thing of all, very high odds ratio. So that's sort of interesting. Anecdotally, I think it's been my experience, it's true when the nurse says, "Oh, this is definitely C. diff," then it usually is. And a group in the U.S. actually replicated the findings of this study a couple years later. Sounds like you've heard of the study with the dog, but I'll mention it as well because it's funny. So in BMJ in 2012, the study was published. It's a real study. I mean, it sounds kind of quirky and unusual, but it's actually well done and published in a decent journal. Where they trained this poor innocent beagle to smell C. diff in both lab specimens and in patient rooms. And so for the patient room aspect of it, they walked the dog around to these rooms, and the dog was trained to sit down or lie down when it felt like C. diff was present in the room. So in the sort of control aspect where they were in the lab, the dog sensitivity and specificity was 100%, which is better than PCR. And then on the rounds, it was actually very good as well. So 83% sensitive and 98% specific for detecting C. diff. That specificity is actually also better than PCR testing as well. So something to consider. There might be downsides to dog-based testing, and there's some evidence that those pet therapy dogs that you see walking around can become contaminated with C. diff and other bacteria. So who knows? But interesting nonetheless. So
colonization versus
that's a good question. I'm not sure what the gold standard was.
Does it mess up the testing if the dog becomes contaminated with C. diff?
Probably, yes.
It lies down all the time.
Yeah, it just shouldn't lie down. Okay, so another question for the group. And this is a pretty straightforward standard case. I think a 69-year-old woman, diabetes, hypertension, heart failure, on dialysis, admitted to KCC with pneumonia, treated with ceftriaxone and azithromycin. On day 3, she's febrile, her white count goes up to 16, and she has watery diarrhea. So you send her the C. diff test, and it's positive. The question is, would you treat this patient with Flagyl or oral vancomycin, and why? So pretty common case, but does anyone have a firm opinion either way?
It's that, I mean, I guess it'll also depends if it's the first time she's ever had it versus the return, but I thought that we were. That may also be.
I think it's more severe C.
Yes,
diff.
severe.
I'm not sure. I'd have to look up whether it's like 16 and 39 meets the criteria or not.
Yeah, so that's the question, if this is severe or not, I suppose.
I like what UpToDate has to say, since it's severe C. diff is variably defined in studies. They say it's up to the clinician to determine whether they think it's severe.
Okay, so it's up to you all. So what? Right.
The criteria starts with a Z or something, or the for severe C. diff. The paper is there's an ICU paper, I think, which is your guidelines.
Yeah, so, okay, all right, so we'll get into it. So next question before we move on, same patient. So let's say you decide to treat the patient with oral vancomycin, but later that day she develops severe abdominal pain, profuse watery diarrhea, hypotension, she's not responding to IV fluids. You call the ICU to consider transferring, but in the meantime, what other treatments might you give this patient? She's not doing well, she's already on oral vancomycin. There's no right answer for this question.
You could give IV Flagyl, but I'm not sure if that actually helps.
Okay. Anything else you do?
Rectal. There was a monoclonal antibody recently that was studied that I go with all the time.
Okay, so maybe Flagyl. I heard someone say surgery, consult,
Fidaxomicin, maybe?
maybe fidaxomicin, maybe IVIG. Anything else? So, okay, you might increase the vancomycin dose. Okay, so we'll talk about it. All right, so the mainstay of treatment, as you know, is to stop other antibiotics if possible. Not always possible, but sometimes it is. And then your approach to treatment really depends on whether the C. diff is mild, severe, complicated, or recurrent. And those are all different. But as you all mentioned, there really is no broadly accepted definition of severity in C. diff. So there are recommendations for how to treat people with severe C. diff, but we don't really know how to define severity. So there are national guideline definitions. This is the Infectious Disease Society of America, IDSA guideline. And they say leukocytosis with a white blood cell count greater than 15,000 or renal failure. So creatinine greater than 1.5 times baseline level. These are the GI guidelines, and they say albumin less than 3 plus either a white blood cell count over 15 or abdominal tenderness. So very different, right, than the ID guidelines. And like everyone has a low albumin in the hospitals, so hard to go by that. And then as well. I mean, that's probably why you sent the C. diff test to begin with. So my favorite guideline definition is the British one. It has a very British title to this table: patient characteristics that could reasonably be assumed to correlate positively with severity of colitis in the absence of another explanation for these findings. Mouthful. But you can see, so I think they consider having any one of these things to be severe, and they give you a lot of potential options. And they include fever, and high white count, but also left shift, and renal failure, and lactate, and low albumin, and all these things. So it's pretty easy to meet the definition of severity depending on which guidelines you look at. And so mild to moderate, if you think the patient has that, then we usually treat with Flagyl. One thing I should mention is that almost all C. diff studies use a 10-day treatment duration, and so it's usually the recommended duration that we give people. Some people give 2 weeks, but that's not really based on most of the published evidence for C. diff treatment. I'm required to disclose to you that I'm talking about a off-label use of medication because Flagyl is not FDA approved for the treatment of C. diff. Sort of interesting. They just never went through the process of getting FDA approval. And so whenever you go to a C. diff talk at a national meeting and people have to give their disclosures, they always have to say at the beginning that they're talking about an off-label use of medication, which is Flagyl for C. diff. Interesting. So as you know, patients don't always tolerate Flagyl very well. There's a lot of side effects. And so severe is usually treated with oral vancomycin. The dose is 125 Q6, which what I said we would give to the patient in that case. It's slightly more expensive, and there's a theoretical risk of increasing rates of VRE colonization when you give too much oral vancomycin to patients in the hospital, but it's probably better tolerated than Flagyl. So, so where do these recommendations come from to give oral vancomycin instead of Flagyl for C. diff? So this is one of the first sort of major studies that was published looking at this. It was a prospective trial of Flagyl versus oral vanco for 10 days in 150 patients. They used their own sort of definition of severity, a point score, looking at age and temperature and albumin and white count. If you had a certain number of points, greater than 2 points, then you were called severe. And what they found was that there was no difference in outcomes between using vancomycin and Flagyl in patients with mild C. diff. But for patients with severe C. diff, the cure rate was significantly better with vancomycin. So this year, actually, in JAMA Internal Medicine, there was another study looking at the same question with even more convincing outcomes. So this was a big retrospective study looking at over 10,000 patients at the VA. And they used the Infectious Disease Society guideline definition of severity, so the white count greater than 15 or renal failure. And what they found was that in patients with severe C. diff, there was actually a mortality benefit to giving oral vancomycin, but not in the mild to moderate C. diff cases. And so there has been a shift recently since this paper and a couple other smaller ones to move towards being a little bit more liberal with the oral vancomycin and away from Flagyl because we don't really know who's severe, and there may actually be a lower rate of death in the severe cases when you're giving oral vancomycin. So something to consider. So dosing comes up for oral vanco, often for hospitalized patients. So you can give 125, 250, or 500 milligrams Q6 hours. And so this study looked at fecal concentrations of vancomycin at the different doses. You can see that there is a significant difference in concentrations when you give higher doses. So this is the 500 milligram dose, and you get a much higher concentration than when you're giving lower doses. So at first glance, it's sort of impressive. You get better concentrations in the stool, but the thing to point out on this chart is that the MIC for C. diff on this scale is 1, and this scale goes up to 12,000. This concentration here is about 12,000. So no matter what dose you give, you're way above the amount that you actually need in the stool to treat C. diff. And so the take-home point from this is that the lower dose is fine, essentially, and that we really reserve the 500 Q6 dose for the patients who are not responding to treatment. And there is a recommendation in severe or complicated C. diff to give that dose, but it's really just based on expert opinion and not based on any sort of firm evidence. So moving into the treatment of complicated C. diff. So the options, so like I said, you can increase oral vancomycin. You can add IV flagyl, like was mentioned. Vancomycin enemas, also mentioned. Sometimes we give tigecycline as well, which actually has activity against C. diff. IVIG, fecal transplant, and colectomy finally is sort of the final option. Should mention that the evidence for most of these is very limited. You can imagine that conducting some sort of high-quality clinical trial on someone that's doing poorly from severe C. diff is very complicated or almost impossible to do. So for the most part, it's small case series, case report level of evidence without a really good control group. There was a study published in 2015 that showed that there is a mortality benefit to giving IV flagyl to patients who are in the ICU with severe C. diff, so critically ill patients. For patients outside of the ICU, it's not really clear. And then, like I said, there were a small series looking at rectal vancomycin, tigecycline, IVIG, and fecal transplant for severe C. diff. FMT, initially the major indication was for recurrent C. diff, but there's been a lot of evidence recently to suggest that it's very effective for severe cases as well. And anecdotally, some of the patients that we've had in the hospital that went to the ICU and looked like they were headed towards colectomy and got like a last-minute bedside flex sig FMT in the MICU did remarkably better the next day. Like people were, it was like an instant cure. Their white count was 30,000, and the next day their white count was 15, and the next day it was 10 and 5, and yeah. So it seems to be very effective. It's obviously risky if they have a lot of inflammation and megacolon, and they don't want to risk doing this procedure and causing perforation. But for people that can tolerate it, it may be effective for severe cases. So colectomy comes up as well for these patients, and the guidelines really don't offer helpful guidance on when to move forward with the colectomy. So they say to consider a colectomy for severely ill patients and to monitor the white count and lactate to help guide if people are responding to therapy. There's a little bit of evidence to support doing the colectomy if you need to. So this study in 2007 was published looking back at 165 cases of severe C. diff in Quebec during that NAP outbreak in the early 2000s. And they were all really sick patients. So they were all in the ICU. 53% of them died within 30 days of going to the ICU. So this is a lot worse than most of the C. diff that we see now, fortunately. What they found was that the people that went for emergent colectomy were less likely to die, significantly less likely than those who were just treated medically. And they looked in the subgroup analysis at who would benefit most, and they found that people who were older, who were not immunocompromised, and I thought the most interesting thing is that they found that having a lactate between 2.2 and 4.9 those were the patients that were most likely to benefit from going forward with colectomy. So if the lactate was greater than 5, then it didn't really matter what you did. Most people died regardless of what they did. And if the lactate was low, then they probably didn't need the surgery to begin with. But if it was elevated but not too high, then those were the patients that were significantly more likely to benefit from colectomy. But hopefully in the future, the FMT will replace the need for this in a lot of patients and help will avoid it because it's really awful and they really need it. So recurrent C. diff, the recommendation is to treat the first relapse like you treated the initial case. So if it's not severe, you can actually just give another course of flagyl, and then for subsequent cases, it gets trickier. So you can switch to oral vancomycin, you can do vancomycin taper, and then you get into fidaxomicin, again, fecal transplants. People give rifaximin as well. We don't do that much at Mount Sinai outside of the cirrhotic patients. So has anyone used fidaxomicin here? We don't use it much at Sinai, mostly because of the cost. But there is good data to support its use in recurrent C. diff. So it's 8 times more active against C. diff than vancomycin. It's bactericidal. It has this prolonged post-antibiotic effect, but it's expensive. So this is a table from a year or two ago just showing the different prices of different options for treatment. In the hospital, we compound our own oral vancomycin from IV Vanco. So they just cut open a bag of IV Vanco and put it in those little syringes to give to the patients, and it's much cheaper than the pills. But you can see fidaxomicin costs about $3,000 for the course, and flagyl costs $20. So quite a difference. But you may have seen this study in 2011 in the New England Journal of Fidaxomicin versus vancomycin for recurrent C. diff. There was a similar one published the following year in Lancet Infectious Disease. And they basically found that the initial cure rates were similar when treating with fidaxomicin, but the relapse rates were lower. And so they sort of combined relapse and cure into something called a global cure and said global cure is better with fidaxomicin, meaning patients are less likely to relapse and not require treatment again in the future. One important thing to point out is that global cure rates were not better with fidaxomicin among patients who had NAP1 infections, and there was no difference between severity groups. So you could speculate that fidaxomicin would be a good drug for patients who had severe C. diff, but these studies don't really support that. So it seems to be effective for preventing recurrence, but not necessarily successfully treating that current episode, and not for the patients who have the endemic NAP1 strain, actually. So I think that the drug company was probably hoping that it would also find another indication for treating severe cases, but that doesn't really seem to be the case. And these are the two charts from the 2 different studies that show significantly lower rates of recurrence in patients who are treated with fidaxomicin. And you can see also, I mean, I'm sure you've seen patients in the hospital who had their 3rd, 4th, 5th episode of C. diff. Unfortunately, in these patients who have recurrent C. diff, their rates of recurrence are pretty high, and their rates of cure are low. So there is a need for a different approach and new therapies for those patients. And so I'm not going to spend a lot of time talking about fecal transplant. Ari Grinspan gave grand rounds a year or 2 ago with some interesting data from Sinai, and I'll just mention a couple of the major studies. So you may have seen this study a few years ago. It was interesting for a couple of reasons. First of all, that you don't usually see studies in the New England Journal that enroll like 30 patients or 40 patients or so, but the outcomes are so striking, and the difference between the treatment groups are so striking that they did decide to publish this one. And you can see, very significant difference in cure rates. And like I mentioned, so the people who were getting vancomycin, their cure rate was only 30%. These are patients who had recurrent C. diff, and so previously the outcomes for these patients were pretty poor, and the people were really struggling. And now, there have been larger systematic reviews and meta-analyses showing really excellent cure rates for patients who had refractory recurrent C. diff, and this one found about an 85% rate of resolution of C. diff symptoms after fecal transplant. And like I said, the sort of baseline to compare to is 20-30%. So quite a difference. So the future might be the pills, though, the so-called poop pills, which don't require the need for colonoscopy or EGD or however else they're introducing fecal transplants now. This is also a small study, but also made its way into JAMA. Just 20 patients with recurrent C. diff who were treated with frozen stool capsules made from healthy donors, look like that. They're pretty big, so I've been told, and they have to consume a lot of them. So their regimen is 15 capsules on 2 consecutive days, so 30 stool-filled pills on 2 days. But what they found is that the diarrhea resolved after the initial treatment in 14 patients, and then in the 6 remaining patients, they retreated them again, and 4 of them had resolution. So 18 of 22 of these patients responded well to treatment. And like I said, obviously it doesn't require the patient to get colonoscopy or some other invasive intervention. So this may be the future of C. diff treatment. So I'll finish by talking about prevention. I think that it's probably the most important part of the talk, because if we're able to prevent these cases, and the rest of it's sort of irrelevant. And there's a lot that we can do. So stopping or limiting antibiotic courses, stopping PPIs if we can, wash your hands, and then stuff that infection control does, like disinfecting surfaces in the hospital, is obviously really important. And I'll mention a couple other strategies that we're using now, like oral vancomycin prophylaxis, probiotics, monoclonal antibodies, somebody mentioned, and then C. diff vaccines are on the horizon as well. So I'll spend just a moment talking about stopping antibiotic overuse. I'm sure that you hear about this all the time in various meetings and lectures and things, but I think you all are sort of on the front lines of prescribing antibiotics and treating patients who have infections in the hospital, and so you can really make a difference by either identifying patients that don't need antibiotics, or in people that do need them, tailoring their course to the shortest possible course of antibiotics with the most narrow spectrum antibiotic that's appropriate. I know some of you are involved in efforts to limit overuse of hospital resources or misuse of hospital resources, and I think C. diff is really the classic or quintessential example of misuse of hospital resources causing direct harm to patients. And I'm sure you've seen cases where people are left on antibiotics for weeks and weeks and weeks by mistake, and we're introducing some things now, like the antibiotic timeout and stuff like that, to try to prevent that. But it's something that we can all sort of work on to help patients do better. And so as part of that, there's been a big push in the ID world recently to study shorter courses of antibiotics for common indications. And the general theme from the research is that for most things, shorter courses of antibiotic therapy is probably sufficient. There's some exceptions, obviously, like endocarditis and osteomyelitis and things, but there have been several studies over the past few years looking, like I said, randomizing people to short and long course therapy. And so this study was called the Stop It trial, which I think is a great name for a trial, and short course for intra-abdominal infection. There's been studies for soft tissue infections, Cochrane review looking at short course for hospital-acquired pneumonia. And then this study is actually not even published yet, but coming out soon, looking at short course versus long course for people with gram-negative bacteremia. And they found similar outcomes just doing 7 days instead of the typical 14 days for people with gram-negative bacteremia. But obviously there are a lot of variables in there, and the source of the infection and how the patient's doing, and if there's any sort of deep focus that hasn't been addressed. But generally, it seems that shorter courses of antibiotics for most things are probably sufficient. In some some of the durations that people use are sort of arbitrary and based on what people have done for years and years, and not really based on evidence. So something to keep in mind. And now we're giving people in the hospital oral vancomycin prophylaxis as well. Are you all doing that at all for your patients? No, so. Yeah, so this is recently instituted at Mount Sinai. We've been doing it sort of informally for years, but just recently there's been some evidence published that giving people who are at high risk for developing C. diff prophylactic oral vancomycin while they're admitted to the hospital can significantly reduce their rate of C. diff. And so this study was just published last year, looking at about 200 patients admitted to a hospital in St. Louis, and they were all people who had C. diff before, and now they're getting IV antibiotics for other reasons in the hospital. And they gave oral vancomycin prophylaxis twice a day to about half of them, and half of them received no prophylaxis. And they found that 4.2% of people in the prophylaxis group developed C. diff compared to 26% in the control group. And like I said, it's something that we'd sort of been informally doing for a while, but we've instituted a bit more of a protocol in the last year or so at Sinai. And so we tend to give people who, similar to the study, have had C. diff before and now they're admitted for some other infection and they're getting antibiotics. We give them twice a day, 125 Q12 oral vancomycin prophylaxis. And I've never seen a patient develop C. diff while they're getting prophylaxis, and so that's a good question. So we usually continue at least for the duration of their antibiotics, and some people give like a tail of PO Vanco after they finish the other antibiotics, so 5 days, 7 days. We don't really know. I think in this study, I think they just stopped when the other antibiotic was stopped. But some of us give a couple extra days just to be on the safe side. But something to consider for your patients who have had recurrent C. diff and now you're starting them on an antibiotic. And I don't think we've done a good job of spreading the word that this is something that's effective and worthwhile to consider. But I've heard that they're making oral vancomycin no longer restricted soon, so they don't have to call the ID fellow and get approval for giving oral vanco. So something.
Maybe this is something that could be changing our practice, because not a lot of our patients we treat for infections don't have an ID consult. So, and we see plenty of people with a history of C. diff. Right. So we should be considering twice a day oral vanco for some.
Yeah. So I mean, the people that I see who've had C. diff recently, and we're giving them antibiotics, I give all of them oral vancomycin prophylaxis.
Because we don't, if someone has pneumonia for 5 days or so, we don't keep them inpatient for 5 days for treatment. So the outpatient treatment is
so that's a little tricky because like I mentioned, we compound the PO Vanco in the hospital, so it's cheap. But if you try to send someone home on oral vancomycin, then they get capsules from the pharmacy, and those are very expensive, and it sometimes requires prior authorization. And so when we send these people home on a couple more days of another antibiotic, then we sort of have to figure out the sort of risk benefit of continuing. You can give people Flagyl, which is also effective, but a little bit not as well tolerated as oral vanco, but that's an option. But for the most part, we just try to do this while they're admitted to the hospital. Yeah.
Would you do this for anyone on any antibiotic, or just someone who's getting like if you're, is it completely regardless of the type of antibiotic that they're getting? Or are there categories that you consider particularly high risk versus low?
Yeah, so cephalosporins, quinolones, beta-lactams in general are the most strongly associated with developing C. diff. So for those patients, for sure. If you say you have a patient that has MRSA bacteremia and they're getting IV vancomycin, then giving them PO vancomycin may not really make a difference. So there are some that are less commonly associated with C. diff, Bactrim, doxycycline, and things like that. But for the most part, your patients that are getting like ceftriaxone or cefepime, probably be a good idea at least consider it. Some people are NPO and stuff too, and can't be on oral vancomycin prophylaxis. But all this evidence is all brand new, but it seems to be pretty convincing. Like I said, huge difference between the rates in those two groups. So patients often ask about probiotics as well. We don't tend to be fond of probiotics on the ID service. So I like this cartoon, but so the published evidence for prevention of C. diff with probiotics is inconsistent. And there are a lot of reasons for that. So there are a lot of different formulations of probiotics. There are different indications that you could study to give it. Patients have different baseline risk of C. diff in different studies. And so it's hard to say for sure if probiotics are really beneficial. Most of the supportive evidence is in primary prevention, so not the patients that I just mentioned who have had C. diff before and are getting antibiotics, but in people that have never had it before and are on antibiotics, and you want to give them something to prevent C. diff. And so there was this meta-analysis in the Annals of Internal Medicine a few years ago that showed, so they included a lot of patients, 20 trials, and they showed a really significant reduction in the incidence of C. diff among patients who were receiving probiotics. So they said there was a 66% reduction in the incidence of C. diff, which is pretty striking, actually. And so they concluded that in a population with a 5% incidence of C. diff, then probiotics could prevent 33 episodes per 1,000 people, which is kind of impressive. But then the following year, in the Lancet, this really well-done and prospective clinical trial was published. 3,000 patients randomized to receive either placebo or probiotic while they're hospitalized and receiving, I think, antibiotics for other reasons. And they found no difference in C. diff rates between the two groups. One of the criticisms of this trial was that the incidence of C. diff in the control group was relatively low, so about 1%. And so that's not, it's a bit lower than you might expect for people that are admitted here and are getting antibiotics and things. And so people said that maybe if they had studied a higher risk group of patients, they would have found a benefit. And the previous study said it would be beneficial if the incidence was 5%. So we don't really know, but this is the highest quality level of evidence that we have for probiotics, and it showed that it wasn't beneficial at all. And so we tend not to give it here, but there are other places that are a bit more aggressive with giving it. I know that there's a hospital in Quebec that recently published their results where they've, since the 2000s, they've given every admitted patient on antibiotics a probiotic. And so they don't have any control group, but they compared their outcomes to their Quebec region in general and found they had significantly lower rates of C. diff or whatever that's worth. I'm sure they do other things to prevent C. diff as well if they're doing that, but we don't really know. So there are some potential harms of giving people probiotics as well, and there are several case reports of people becoming bacteremic or fungemic as a result of their probiotic. The major risk factor for this seems to be people who have central venous catheters. So the nurse administers the probiotic and touches it with her fingers and manipulates the catheter, and we think that it sort of gets inside that way. And I think there were a couple cases in the SICU here a few years ago attributed to that. So something to keep in mind for your patients who have central lines or who are immunocompromised. So several reasons to not give it or consider not giving probiotics. We do have Saccharomyces Floor Restore on formulary at that time. And so someone mentioned monoclonal antibodies. So just this year, the study was published, bezlotuximab, which is now FDA approved for the prevention of recurrent C. diff. There were actually two prospective trials, and what they found, so this is an antibody against the toxin B. They had one against toxin A, which was not effective, but they found significantly lower rates of recurrent C. diff among patients who received a single infusion of this monoclonal antibody against toxin B. It's given at around the time of C. diff treatment. It costs about $4,000, and so, like I said, it just received FDA approval this year, and we don't really know how, if at all, this should be incorporated into treatment of our patients. I think cost is going to be a major issue. And then finally, I'll just mention there are several vaccines that are in development, and we may end up being one of the study sites for the phase 3 trial of that first one. Also not clear how these should be appropriately applied to patient care, but I think, at least from the drug companies, the thinking is these would be for patients who are being admitted to the hospital for some elective procedure. They're getting hip replacement surgery or something, and they might be at risk for C. diff, and so they get a vaccine before they come into the hospital, and it helps keep them protected from C. diff. But I guess the phase 2 study for that first one was promising, and the phase 3 one is ongoing. So we'll see. Interesting. Okay, so just to finish up, a couple of take-home points. So limiting antibiotic overuse and misuse is really the key to preventing C. diff and also to treating it effectively. I mentioned that, but sometimes it gets forgotten that if the patient's on an antibiotic they don't really need and they have C. diff, then stopping it is really the most important thing. So I personally have a low threshold to give people oral vancomycin because we don't really know how to define severe, but we know that people with severe C. diff do better and may have a lower mortality rate when they get PO vancos. So something to keep in mind. And then also, I would consider giving people a prophylaxis like we talked about. If you think your patient's at risk for C. diff and they're requiring other antibiotics, then you can call your friendly ID colleagues if you have cases of complicated or severe C. diff or any other C. diff questions. And it's an interesting field. I mean, like most of the studies that I showed you were just within the last couple of years, and so a lot of this stuff is really changing and developing really rapidly. So there are new things on the horizon. So. Any questions? Yeah.
So, this came up recently in census assessment of ID. Patients who are treated for C. diff may be mild to moderate course. They complete the 10 or 14 days they've been given, and they're still having some diarrhea, not throughout the day, but some. And to what extent, when do you say that they have failed treatment versus I was speaking with some people from ID saying, there's perhaps a delay in return to normal bowel activity, and how do you know that if they're how do you decide whether they're
yeah, that's a good question. So some people can develop sort of like an IBS syndrome after they have C. diff, and it can be hard to tell if it's refractory infection or something else. So if you look at the guidelines for C. diff, it says not to send a test of cure test, and they're pretty explicit about it in any of the guidelines. It says do not do this. There's no evidence to do this. But to be honest, I sometimes do it in cases like that, and it's been extremely helpful. Because like I mentioned, people who are treated, the old teaching was that it stays positive forever or months and months, and it's not worthwhile checking again. But it does become positive in some people who have only been on treatment for a couple of days who are responding to treatment. And so we've had a couple of cases like that where they're having diarrhea and it's not clear what's going on, and we send another C. diff test and it's negative, and then it's like I said, it's pretty sensitive for detecting infection, and so you can focus on other things at that point. If it's positive, then it's a little bit trickier to interpret, and it could just be sort of a remnant from a treated infection. But you just have to sort of have a plan for how to interpret it before you get the result back. But the couple times that I've sent it and it's come back negative, it's been really helpful. Any other questions? All right, thanks.